Hello and welcome to HRStv in this author interview. I'm Jeanne Poole, the editor-in-chief of HRO2. And today I have with me Dr. Giudicessi, who has written a very interesting paper entitled Prevalence and Potential Genetic Determinants of Young, Sudden, Unexplained Death Victims with Suspected Arrhythmogenic Mitral Valve Prolapse Syndrome. This will publish in our October journal. Dr. Giudicessi, it's just really wonderful to have you with us here today. This is a topic that I've always been very interested in. We all unfortunately see patients who have suffered sudden cardiac death or sudden cardiac arrest who have myxomatous mitral valve disease, and have known for decades that there is a small percentage of these people who have a malignant arrhythmic syndrome. And here in your paper now, you actually try to get deeper into the genetics of what might be associated with that particular malignant group. So tell me a little bit about what you did and why you all chose to do this particular study.
Yeah, well, thanks, Dr. Poole, and the entire team for having me. It's really a pleasure, and thanks for publishing this work. It's a great question. I mean, at the end of the day, in 2013, Dr. Ackerman, who's the senior author on the paper, provided the central description of the syndrome that is now kind of known as arrhythmogenic mitral valve prolapse syndrome, right? And at that time, it did not appear that there was any sort of a familial component. So really the motivation came when I was a cardiology fellow at the beginning of my fellowship. I was fortunate enough to be involved in the care of a patient who had a strong family history of both myxomatous mitral valve prolapse and sustained ventricular arrhythmias and sudden death. And so that kind of got the wheels spinning that maybe there's something deeper to this syndrome. Maybe it's not a non-genetic syndrome. And that eventually led to us actually sequencing whole exome and whole genome, sequencing that family, discovered a truncating variant in filament C. That work was published in Mayo Clinic Proceedings, I think, in 2019. And then I was left with the question of where do we go from here? And so unfortunately, because it was not labeled as genetic or as familial, we weren't enrolling patients in a biobank or anything of that nature. So the next step I looked and said, what do we have? And so we did have an exome sequence cohort of sudden unexplained death in the young victims. So I said, okay, we know that there's been this association both in the living sudden cardiac arrest survivors as well as in decedents. Maybe it's time for us, it'd be a good opportunity to, one, confirm the findings of the Italians and other groups, as well as use the fact that we have exome sequencing genetic data on these patients to dig a little bit further and provide some additional data as to whether or not there truly is the possibility of a genetic basis to the syndrome.
Well, this is great. This is definitely a novel study. Can you just give me some of the big highlights of what you did and what you found?
Of course, of course. So at the end of the day, the major findings of the study, I think, are really kind of twofold, right? So the first is we confirmed that 6 out of 77, or roughly 8% of the autopsy inconclusive sudden unexplained death in the young cases that underwent exome sequencing had evidence of myxomatous mitral valve prolapse, either clinically or via autopsy kind of, basic pathology as their lone finding, okay? And that's consistent with prior studies. So we've seen across the globe, studies range between 4 to 12% is the overall kind of prevalence of mitral valve prolapse in these kind of autopsy cohorts, right? And so that's the first takeaway, is it really confirms in a US cohort, which is one of the first to be done, that yes, indeed, we're seeing this as an international phenomenon. And then secondly, what's probably more interesting to the readership about this is that in comparison to those decedents who did not have mitral valve prolapse, we really saw two findings. The first is, one, they have an increased likelihood of having endocardial or interstitial fibrosis on histopathology. And then number two, which was really surprising to us, these patients had an increased likelihood of having a pathogenic or likely pathogenic variant in a strong evidence channelopathy or cardiomyopathy susceptibility gene, which if you'd asked me at the beginning of the study if I thought I'd see that, I would have told you no. And so that came through. It's underpowered. It's a small study, but I think it's providing us with a little bit more of a glimpse of maybe there is something there. Maybe there's a little bit more digging that needs to be done in regards to what's driving the risk in these patients.
So you can correct me if I'm wrong, but I took away from this that maybe the way to start thinking about this is sort of like what we do with non-ischemic cardiomyopathy, that now is not just non-ischemic cardiomyopathy, but we're able to identify specific high-risk genes, and there's a common pathway, which is systolic dysfunction. And perhaps this is a 2-hit or 3-hit sort of situation for myxomatous mitral valve disease. Is that really how you're thinking about this now?
Yeah, I think, and I think hopefully with some of the data that's going to be coming out, I think what we're beginning to look at this is say, look, this may be, at least in a subset of cases, maybe a two-hip hypothesis. So you have genetically unrelated mitral valve prolapse on one end, and it collides with an underlying genetic substrate, likely a cardiomyopathy, susceptibility gene, something like Titin, something like filament C, and then it's going to, exacerbate, the base of the tension on the wall, on the inferior basal wall, is kind of having an out of proportion fibrotic response because of the underlying myocardial substrate. And that's what we're looking at least for a subset of these patients, I think, is that there's a collision between those two genetic substrates relating that two-hip model, which I think is something that we really need to kind of pursue further and determine if it's something that is truly, truly a real finding.
Well, I think it does fit with some of our clinical observations. In our patient population, we do a lot of MRIs on, non-ischemic cardiomyopathy patients, or these patients that look like maybe they are arrhythmogenic mitral valve prolapse or myxomatous mitral valve disease, whatever you want to term it. And, we often see areas of scar around the papillary muscle structures and even in other areas of the heart. So it seems to fit with what our cumulative clinical perspective is. So, how do you think we should start thinking about these patients in our clinical setting? How do we change how we manage these patients and try to prevent sudden death?
No, it's a really great question. I think one of the big takeaways kind of from this paper that I think you can say is, I think we need to take a family history for these patients, right? And so I think that's a big thing that maybe we didn't realize. And in fact, if you go and look at some of the old records from some of the early patients that we'd seen, no one really bothered to look at it because everybody's kind of thinking, well, either the family history doesn't matter for mitral valve prolapse, or, we just weren't thinking that this was a familial disorder. So I think that's the first takeaway, is that if you're encountering these patients in the clinic, we ought to be talking about their family history, seeing if there's something to suggest there's a genetic basis to it, okay? So I think that's the big takeaway from this paper. Whether or not the specific variants and the genes hold, I think that's a big takeaway. The second is just increasing awareness, and I think that's already there, that, again, mitral valve prolapse is not a benign condition, and we really have a lot of work to do to figure out what are the biomarkers, both from an imaging perspective, but as well as maybe looking more for serum biomarkers, other things, to figure out how do we differentiate the very small number of patients that are going to go on to have some sort of ventricular arrhythmia or sudden death from the 2 to 3% of the general population that has benign, otherwise don't worry about mitral valve prolapse. And we're not very good at that right now. And I think that's where, kind of the conversation has to go as we head towards the future.
Yeah, I think these patients have been disserviced greatly by lumping them into this sort of benign, this is not a big deal kind of clinical entity. And, patients get missed who are starting to have ventricular arrhythmias or non-sustained VT. And then the next thing that happens is they have a cardiac arrest. So I think sort of changing that whole paradigm about how we think about these patients. And again, I couldn't agree with you more on the family history. I don't think that we have emphasized that enough. Residents need to be taught this, fellows need to be taught this, that taking a very careful family history is so critically important in these, patients without coronary disease as the cause of their heart failure. Well, where do you see this going then? What do we need to do next to try to make this be a little bit better understood and turn this into, genetic testing that we can put into our entire panel of genetic testing that we have available to us now?
Yeah, so it's a fantastic question. I think the first step we've already started. So we do have a living cohort of arrhythmogenic bileaflet mitral valve prolapse syndrome survivors that have, kind of meet the strict clinical criteria. And we've enrolled them in a biobank and in the process of genome sequencing about 50 index cases right now. And so our hope is that within the next year or so, we'll have that data available. Now, I don't think it's going to just start and stop with a Mayo or a single center study. I really think there's going to be the need for a multi-center registry for this. There's a clinical registry undergoing through the University of Michigan that we're going to participate in. I hope other institutions will as well. That should provide some additional information, I think, going forward. But I also think we need to have an international biobank and begin to figure out how do we combine everybody together, use GWAS, use more sophisticated genomic techniques to get to what's causing this. We also need to go back to those families and look at it as, this is just one finding, this two-hit model. Maybe there's novel genes there, right? And that's another thing that we're working on, is we've got some bigger families that we're trying to dissect using next generation sequencing, some other techniques, as well as looking to do IPSCM models to figure out what's there, right? That's all going to be needed before this ever translates into clinical practice. But for now, I think what people can take away is we're seeing enough of a signal from the cardiomyopathy genes that if you're worried there's a family history, that sending an Invitae detect or a pancardiac panel through somebody who understands the nuances with variants of uncertain significance might be something that's a reasonable or rational thing to do, because there does appear to be a little bit of an overlap with the non-ischemic dilated cardiomyopathies, that I think that that's also a rational thing that people can begin to think about doing.
Yeah, I mean, VUSs are always difficult for us who are not in your world to interpret, but I think you're right. I think we can, because we send genetic panels, really frequently, again, on all of these patients. And if we see some of these VUSs, at least maybe we can take a look at that now and sort of say, maybe there is some signal here. And again, that ups the ante for how we're going to think about these patients and potentially treat them.
Exactly.
Any last words for us?
No, again, I thank you for having me on. And I think, again, hopefully this raises awareness of this condition. We can begin to change that paradigm as we talked about, and as far as how we approach mitral valve prolapse, knowing that, again, there is some risk of sudden death. And for folks just to know that there's a lot of ongoing research in this area and to stay tuned for those future developments. So I thank you again.
I'd really like to thank our author today, Dr. Giudicessi, for joining us for this author interview. We invite everybody to read this very interesting article in the October issue of Heart Rhythm 02.